Okay, we'll see. All right, so what we're going to start with today is the intrapartum fetal heart rate monitoring. Um, this is something that's ubiquitous on labor and delivery. You'll always see those fetal heart rate tracing. It's on your exams. You have to know more or less how to look at it. After a while, you'll just be able to look at the tracing and know pretty categorically what's going on. Usually the ambiguity lies mainly in when you're having a lot of artifact or you're not picking it up well enough. That's really what your problem lies in primarily. So I definitely encourage you to review this. We'll go through some cases and examples that I'll kind of come up with on the fly. And thereafter, when I'm still working out the mechanics for your simulations, but what will happen then is that you'll be brought into a room and then the tracing will be on the display. And then it'll say, okay, this is your tracing, this is your situation, what do you want to do? So let's get right into it. So let me get the pointer. Okay, so your fetal heart rate monitoring can be considered the most common obstetric procedure, right? Every patient is going to have more or less continuous monitoring when they're in labor, and this also applies to your antepartum testing as well. We always have to remind ourselves is that in the Northeast, that sort of is the culture to do continuous fetal monitoring with all labor, but situations where you don't have to have it on the whole time, which is referred to as intermittent monitoring, is very much a thing and happens in other parts of the country and across the world. So there's always a policy for monitoring the fetal status, which follows these same rules. It's not always continuous. Just keep that in mind, okay? So fetal monitoring doesn't necessarily mean that it's continuous fetal monitoring, but most every labor and delivery unit will have some sort of monitoring, but make no mistake that there's a lot of controversy about the use of it because there's a lot of inter-observer and intra-observer variability, interpretation and management algorithms, and really there's no evidence to suggest that this helps. It really just increases. It's been shown to increase the rate of cesarean deliveries and operative vaginal deliveries. I mean, that being said, it's not that they're completely ineffective. They have to be managed in the correct way, which is sometimes difficult based on this and that. But if you truly have a good understanding of what it's telling you and what its limitations are, and put everything together, it's an essential component of anything. And it's going to be used anyway, regardless of your opinion about it. But as a, obviously as a clinician, I'll tell you, there's situations where there have been emergency situations for which the fetal heart rate monitor or the electronic fetal monitoring has most certainly identified, and truly so. And other times you have to be a bit more conservative about what it's telling you to be more likely to resuscitate versus doing a cesarean delivery, because it's something that, while concerning, can resolve. And hopefully you'll have a better sense of that after this presentation. So this is what a fetal heart rate monitoring strip looks like. So eventually this image becomes something that's easy to interpret. There's a couple of key things that I want to bring your attention to immediately. The first one is that this is the fetus's heart rate, okay? So that's the fetus here. This one here is the maternal heart rate. Now, the maternal heart rate should be less than the fetal heart rate, right? So the fetus is usually the first line. Sometimes you'll have interesting situations where the fetal heart rate baseline range, which we'll get into, but its lower end is 110 beats per minute. Sometimes you have a mom who's tachycardic to like the hundreds, one teens. And sometimes that's their baseline. So you'll have the lines be really close together. So you have to be pretty careful, because sometimes if you have fetal bradycardia, is that mom or is that baby, right? So that's why it's good to have both of these and have a good understanding of what your baseline is, okay? This is a little light on here, but these numbers here correspond to the beats per minute, okay? And then what you'll see is usually there's annotations by, usually the nurse will do this. There'll be time points. This person, for example, was checked. Well, this is a velocity, but sometimes they'll say, ruptured membranes, 3 centimeters, blah, blah, blah. Don't worry too much about that because there's a lot of variability between the actual program. But the essential parts are fetus, mom, and these are beats per minute. Down here, and this is separated by a gap because it's a different measurement. This is what? Do people know? Yep, excellent. The uterine contraction. So obviously this mom here is not contracting at all because it's a straight line. But your activity will, look something like this, right? So each of these boxes is about a minute. Something very important to know about these are not exact measurements, okay? They're always an estimate. There's no computer algorithm saying what exactly it is. It's truly a visual estimate. And by virtue of that, it doesn't have to be exact. Whether it's 135 beats per minute or 140, it really doesn't matter as long as it's normal, okay? For a fetus, you want variability in this, in the fetal heart rate. So basically you want it to look kind of like squiggly, all right? That's not really so with a maternal pulse. You may have some variation, but you may not. It kind of doesn't matter. Like if you think of yourself as like, is your heart rate really kind of going so erratic? Not really. So each one of these boxes is about a minute. These are the border of the boxes in case the display is, right? And then there's a measurement here. So this actually is measuring the pressure, but it only is valid if you have a pressure catheter in, okay? Usually you don't, you usually just have it on the belly, an external monitor. So this is really just telling you the frequency. These numbers don't count unless you have a pressure catheter in there. And we'll talk a little bit more about that. This is saying fetal movement, these bars, but that's not, they all don't have that. So don't worry about that. So really it's just 3 components essentially: fetus, mom, and contractions, okay? I will put it all together. This nomenclature part is a bit dry, but I'll go through it quickly and then put it together so it makes a bit more sense. So there's a couple of different components on the fetal heart rate tracing that you need to be aware of, and they're more or less mutually exclusive, meaning that, I mean, they're independent, I should say. What I mean by that is that you could have a normal baseline, but a less than favorable variability. You could have a low baseline, but your variability can be acceptable, okay? So they don't really depend on each other. Situations will sometimes pretend for both of those components to move in the same direction, but they don't depend on each other, if that makes sense, okay? When you get into your research and scholarly activity group, you want to think of independent variables, meaning that they do their own thing, as opposed to dependent variables, which would be like an outcome, okay? So accelerations and decelerations in the fetal heart rate, accelerations if it has a period where it goes up, deceleration when it goes down, and there are certain definitions for that. Your uterine contractions, and then putting it all together, okay, putting it all together in categories 1, 2, and 3, okay, with 1 being good, acceptable, continue present management, 3 being an emergency, usually requiring a cesarean delivery, and then 2, which is indeterminate, which is you got to do something. So it's like a bird's eye view. But so for a baseline, and if you have a question, interrupt or raise your hand, okay? So a baseline fetal heart rate, like I said, it's rounded in increments of 5. It's not like you're gonna say, all right, fetal heart rate's 132. To be like, what? Because it's all visual estimates, right? So these things are measured for 2 minutes in a 10-minute segment, okay? So that's why what I always will tell the residents is like, you don't watch a pot boil and you don't watch a fetal heart rate unfold because you need 10 minutes, right? Because if you just look at the little spick, it doesn't tell you anything, okay? So what you need to remember is that the normal baseline is 110 to 160, okay? So if it's within that range, it's fine. So that's why it kind of doesn't matter. If it's 130 or 140 or 150, it doesn't matter. It's normal, okay? You want to know what a baseline is because if there are changes to that, that's something you want to be aware of, but having a baseline change is acceptable, okay? As long as it's within the normal range. Now, tachycardia for a baby then is greater than 160. And what's a reason why a baby might have tachycardia? It's the most common reason why, really. The most common reason why a baby will have tachycardia is infection, okay? Infection like called intraamniotic infection and inflammation, which is triple I, that's what it is. It's intraamniotic infection and inflammation. So 3 I's, okay. You'll hear triple I and you're like, where are those 3 I's coming from? Older resources will say chorioamnionitis is the same thing. They changed it because they're saying, well, you know, it's a more descriptive disease and just in chorioamnionitis, meaning that the chorion and the amnion are infected, which is true. So obviously it's true. Like I'm going to refute that. But other reasons why sometimes when mom's very dehydrated and she's tacky, baby becomes tacky, okay? Or pretty much any other reason that's going to make mom tachycardic systemically will make baby tachycardic as well. If she just has a high baseline heart rate, which a lot of patients actually have, baby won't be tacky. That's just mom's baseline. Bradycardia is the opposite. That's when you have a fetal heart rate that's less than 110 beats per minute. And there's not really situations where you have benign fetal bradycardia. That's usually due to distress. Sometimes every so often you have a patient whose the fetus is like 100 beats per minute. And you're kind of like, oh my God, what do we do? And really it's normal. That's not very common, but generally, if you want to remember kind of like a take-home message, bradycardia in a baby is usually not a good thing. And it's usually not a normal thing, where tachycardia can be. So when we talk about variability, so a baseline will pretty much tell us if we have this sort of thing. If you draw an imaginary line, wow, that wasn't very good. But anyway, if you can imagine drawing an imaginary line through this, that's your baseline. How it goes up and down, the fluctuations, is your variability, okay? And there are a couple of flavors of that. Your first is absent. Then you go minimal, moderate, which is actually what you want, and marked variability. So we'll start with normal. The definition is that it's 6 to 25 beats per minute, but your characteristics sort of look, moderate variability looks like this. And that's actually the way that you learn it, okay? Because it's all a visual estimate, like I said. So this is all just going to be your moderate variability. This is what 6 to 25 looks like, okay? Now, absent is more or less a straight line. Little blips here and there, but even just like something that looks like this, like even if it goes down a little bit, that's absent variability. And absent variability will actually look a lot like your maternal baseline. Not many fluctuations. That's not good. Remember that you want it to fluctuate. A minimal variability is less than 6, but greater than absent beats per minute. Sometimes I have them. I mean, less than 6 meaning 5, right? Sometimes I ask you this, but not really. Usually they'll give you the thing and say, what is it? Interpretation is what they want you to know. And that's what we care about too. So that's absent. Minimal variability looks like this. Do you know from your background reading what would cause minimal variability? Because absent variability is actually always pathologic, I would say, okay? That means it's not going in the right direction. But minimal variability can be normal under certain circumstances. The most normal circumstance being that baby's asleep, okay? A sleep cycle is a normal reason why you would have minimal variability, okay? And then you'll see that you could do something called a vibroacoustic stimulation, where they basically put a rotary sort of device on the maternal abdomen, and then baby like wakes up and then it gets moderate again. They actually did a cool, it was a randomized trial actually, where they said they took like just cell phones to see if that can stimulate the baby as the thing, and it actually showed that it does the same thing. It makes sense that it would, but it was like a very sophisticated design, which I thought was great. I really would love to reproduce that, but we'll see once the pandemic kind of calms down a bit. But yeah, so that's a normal reason for minimal variability. Okay. Minimal variability also can happen in situations where you give mom a medicine that is a depressive medicine. Like sometimes for pain management, you can give butorphanol, which I really don't like, but you could give morphine, which they've been doing since antiquity, works very well. But it also might make baby a little flat, that's a common sort of speech that you'll hear. And that's because that's just what the medicine is doing. You're not worried too much about the fetal status because you know that's going to happen. That's minimal variability. It will never make it absent though. Okay. That's what you need to kind of remember. And then obviously minimal variability, if you're kind of trending in a direction where there is fetal distress, that's not a great sign. But minimal variability in and of itself and everything else looks okay, like the baseline. Like here, for example, this is a normal baseline, right? What would we say this baseline is? Yeah, 145, 150, probably 150 more about here, but before that, it's fine. So you're not too concerned about this. This is your moderate variability, as you said, and marked variability is kind of, it's not bad. It's not moderate, pretty much. Actually, when I was in residency, I was able to ask one of the people, one of the older guys who kind of was involved with the creation of it. And they were just like, well, it's not moderate, which we know is consistently associated with good things. So it's not that marked is bad. It's just not moderate, right? We kind of make jokes about like that the baby's like really active, like raging and stuff, but it doesn't really, this is something that is technically would be referred to as category 2 because it's not moderate, but this doesn't really mean anything, or at least it's not directly associated with a pathologic condition. So don't worry about it. You got to be careful with this because you got to make sure that it's not just artifact that you're getting that's making it look like this. But really the ones you want to kind of look at are these 3, because that's where your decision making is primarily determined. Okay. Questions there? So right now you have your baseline and you have your variability, all right, which is really the most important parts. So now it's either going to be if you have accelerations or decelerations, and then those are in relation to what the uterine activity is doing. And you'll see what I mean by that. So accelerations are, you have an abrupt increase in the heart rate, and that you can have a prolonged acceleration that lasts for 2 minutes for less than 10. Remember, you have that 10-minute window. If you have an acceleration that lasts more than 10 minutes, it's called a baseline change, but baseline change that goes up. If you have a deceleration that lasts more than 2 minutes, that's not prolonged to the floor. That's that's also a baseline change, just lower. You can have, say, a deceleration from 150 beats per minute to like 120, it goes down. It doesn't usually go down, but it can go down like this and stay there. If it's still within normal range, that's a baseline change. But just a little comment here. So at 32 weeks and above, an acceleration has to be, you can think of it like 15 for 15, it has to be for 15 seconds above baseline. In an increment of 15 beats per minute. So 15 seconds, 15 beats, as opposed to if you're less than 32 weeks, it has to be only 10 for 10 beats per minute for 10 seconds. And the reason for that is, to put it kind of concisely, when the younger the fetus is, the less reassuring the tracing looks in terms of it's fitting into the categorizations. So you won't have as well as expected variability. Sometimes you'll have little fluctuations. You'll hear, the reason why I mention that is that sometimes you'll be on the floor and you'll hear a resident or attending say, "Oh, well, it's pretty good for a preterm tracing." That's what they mean by that. Okay, and the criteria is slightly different. For you, it kind of doesn't really matter because it'll be pretty obvious based upon what you're looking at. But just keep that in mind. So an acceleration looks like you have your sort of baseline here, right? So you have this. Now they're not including this, so I'm assuming the patient's above 32 weeks gestational age. And then you have this bump here. Okay, then it goes back, right? And it looks like another one is starting. That's it, just like this. And then your baseline resumes. So, mhm. Yeah, I mean, it has to be for at least 15 seconds. Accelerations, you don't generally describe their duration because it kind of doesn't matter. That's why it's like if they're there, great. You know, the reason why they have a definition is because sometimes you'll have, you know, an artifact that kind of goes like this, or like a blip, right? And then it's like, well, that's not indicative of fetal reassuring fetal status. That's just an artifact. That's the reason why they give it a definition. And it's a fair question to say, would you define it as like, is it necessary to kind of say how long it is? And yeah, you probably would say that's a little more longer. I think that's probably good, even more than actually, because if this is a 1 minute, right? Then this here is probably maybe like 30, 40 seconds. But you don't even have to go that far. If you can visually understand that, that's excellent. So, but that's the deal with accelerations. Accelerations are, for a laboring patient, they can be there or not. If you don't have accelerations, that doesn't mean there's a problem. When you're talking about antepartum testing, meaning that the patient's pregnant but not in labor, you do want to see accelerations, okay, for it to be reactive. And I'll get into that a bit. Accelerations you don't care about. A deceleration, yeah. And it really depends on how bad it is. And I'll show you an example of that. So accelerations, they kind of like, obviously, if they're there, they're good. There's never a situation where an acceleration is bad. Only exception being if you accelerate into fetal tachycardia and then it stays there, then it's not an acceleration anymore, is it? But but the good questions. So now we're going to talk about decelerations. There's a couple of flavors of decelerations, and this is why we care more, because this is where you're going to potentially think that there's a problem with the fetal status. I'll tell you right out, your early decelerations are not indicative of fetal distress, but it's a decrease in the fetal heart rate, a gradual decrease, meaning that it's not just like boom, it's just it has a slight latency to it. Now you'll hear some verbiage that is like on the onset to the fetal heart rate nadir of 30 seconds or more. So what does that mean? Basically the early decelerations and late decelerations are always referenced and are identifiable in the context of uterine contractions, okay? That's what makes them early or late, because it depends on when they start in reference to when the contraction starts. So that's what you have to understand about the decelerations. So you have a contraction here, right? So when this starts, the contraction starts, an early deceleration will also start, okay? This image is shown to highlight the contraction, the deceleration, but keep in mind that your variability doesn't just like disappear. Like the variability here will be the variability here. So it'll look something like this, right? But the graphic thought it might be a little bit too hard to see that, but this is what it would look like. So when the contraction starts, the deceleration starts. The nadir is talking about like the lowest point, and that will match the peak of your contraction. I told you that this is not a problem. This is a little blurry, isn't it? But I told you that wasn't a problem because of why it's happening. So what's happening is that the fetal head is being compressed. The physiology is the same in people. I mean, in adult patients, where that the body thinks there's increased intracranial pressure, so it lowers the heart rate. That's why when you see people are stressed, they'll reflexively like kind of push their eyes in because that is getting the heart rate to go down. It's called a oculocephalic reflex, which is kind of fun. But that's why that's why the heart rate is lowering. And then once the pressure goes out, it goes back up. So this is when you see this, you're actually partially reassured because you're saying, oh, well, maybe she's ready to deliver now because the head's low, right? Especially when you see that with every contraction. So you're like, all right, great. Maybe she's fully dilated. But this still maintains in your categories 1, 2, and 3. This still rules in for a category 1 when you see it. Okay. Now, a late deceleration is when your peak of your contraction is when your late deceleration begins. Okay. And then you have, and keep in mind that your early decelerations and your late decelerations are generally not very deep, meaning they don't go down very much on the monitor. It's not 100%, but a common rule you could think of is that when you see a deceleration that has a very big dip to it, kind of like a bucket, you're probably dealing with a variable deceleration, which I'll get into. It's not like it's a heuristic, but it's not 100%, you know. But just you'll see these examples when it's like this. So that's sometimes what'll happen is you'll have a fetal heart rate tracing and you have these really deep scoops and people are like, oh, it looks like late decelerations, but they don't really do that. So that's not always true, but that's true most of the time. But late decelerations are the ones that you're concerned most about because that actually means there's uteroplacental insufficiency. It doesn't mean that like the placenta is dying, but it means that for whatever reason, baby's being suboptimally oxygenated. Pretty much, baby's stressed, and it's real stress. Okay, so you have to do something about that. Doing something about that means there's resuscitative techniques that you try, and if that doesn't work, then usually you have to consider some sort of form of expedited delivery, be it cesarean or whatever the situation is. And that'll become a little bit more apparent as we get on, especially in the labor management, but I'll put them together in a way that makes sense. So questions with this. Keep in mind, your decelerations are independent of your variability, are independent of your baseline. You could have a good baseline and good variability, but late decelerations. And then what you'll hear providers say is that, oh, well, it's okay because she has good variability. So what does that mean? That means that if you have moderate variability, that means that where the fetal status is good or reassuring anyway. So if you're having late decelerations, well, it's probably something that will respond to resuscitation. Resuscitation, I guess I'll skip to that now that we're talking about it. And by the way, all the stuff comes from the ACOG practice bulletins, so it's the most up-to-date things. So your resuscitative measures really include 3 broad categories. And we'll get into them a bit more specifically, but just to mention them, you want to promote fetal oxygenation and improve uteroplacental blood flow. So your late decels are pretty much saying that there is a problem with those 2 items. So you have to improve that, as evidenced by saying recurrent late decelerations here, okay? Or minimal or absent variability, as we said, okay? Even just by virtue of the fact that there are 2 different lines and not the same thing. So what you can do is, this is what's commonly done. That's why it says potential interventions, but really repositioning, like moving mom side to side, is usually what is the most efficacious in terms of in terms of actually getting something to change. And then you can give mom oxygen, you can give her an IV fluid bolus. That's something that's done. And actually, if you look into the systematic reviews and meta-analysis looking at those two interventions, it really doesn't do anything. That being said, it's probably never going to not happen because people like it in terms of it's reassuring. But and then reducing the uterine activity. This is only important if you have something called tachysystole, which I'll get into. And then your other, reduce uterine activity. And then another goal is to alleviate the cord compression, but you're also doing that with maternal repositioning, if you think that's happening. Okay. So now your variable deceleration occurs when you have an abrupt decrease in the fetal heart rate that is of the same time frame, but it's not associated with uterine contractions. Okay, so you'll have something like this. You have a contraction pattern, and then you'll have it's inconsistently related with your contractions. You see that? This one is, I don't get a straight line, but pretty much this, if I go slower, see, they're just not, they don't line up. And that is indicative of umbilical cord compression. Okay, you see that a lot where after you perform an amniotomy, which is rupture of membranes, the artificial rupture of membranes, then this may happen because now there's not enough space. And the treatment that works best is something called an amnio infusion, where you pretty much put a catheter in and put a little fluid back in a continuous way, and that gets rid of this. It's called amnio infusion. Now, that's also good because what does your amnio infusion is also is called an intrauterine pressure catheter, and that'll give you those numbers to measure the strength of the uterine contractions, which also helps. So speaking of contractions, and there's something called a sinusoidal pattern that they test you on a lot, but I've actually never seen, and I'm convinced isn't a real thing. But that's supposed to be indicative of fetal anemia. Fetal anemia being that the best way I could kind of understand what this is that if a baby has ongoing inadequate blood flow to the point where it actually is becoming anemic, you'll have a pattern like this. But to see this would mean you would have to see that happening before there was a problem. And because monitoring is so good these days, you usually don't see this. That's why we don't really ever see it. If you're tested on it, it kind of looks like atrial flutter on an EKG. It's supposed to be a sinusoid, like that, but it looks more like this, which is not really sinusoid. It looks more like a flutter pattern. This is really academic more than anything. You won't really see that just because if you're seeing this, it's usually a late stage result, and it's either there would have been a poor fetal outcome, or you're looking at a category 3 tracing, which you could do something about. But just keep in mind of what that is if it comes up. Yeah. Yeah. Mm-hmm. Well, you would never have a market variability with a sinusoidal pattern, because if we're saying that that's indicative of like a really prolonged problem, what variability are you going to have? Minimal or absent, right? And that's why you see it here. See, this is absent, more or less. So yeah, this is absent variability here. Maybe minimal over here, right? So you're not going to have good variability. So that's what I meant when I said things kind of do follow suit, though. They are independent, but certain clinical situations line up. Like it wouldn't make sense to have market variability and like something like that. But you can have late decelerations and have moderate variability, for example. Usually you have that situation when there's a problem with the placenta itself, but baby's fine. like a placental abruption sometimes looks like that. Because there's a problem with the blood flow, but the blood flow of that baby's fine otherwise. And it's because the placenta is going to pop off. That's really why it is. So sometimes that's how you segment it. But so that's why usually you can identify it as something. If it's truly something like odd, it's usually because there's an artifact, meaning that like there's something wrong with the monitor or something like that. So if you're looking at it, you're like, I don't know what the hell this is. Usually maybe the monitor's in the wrong spot, or sometimes moms are like touching it or something like that, and it's giving you these weird blips. So if that happens, because I told you there's external monitors, right? But the intrauterine pressure catheter is how you would get the contractions, and that goes inside of the uterus. There's something called a fetal scalp electrode, where you basically put the tube on the baby's head, and then that will get your fetal heart rate, and then you can take the external monitors off. And that's actually preferable when you can do it. It doesn't bother baby at all, especially because in labor, usually there's a little bit of swelling on the baby's head. So it doesn't matter. It's not like when they used to do like fetal blood sampling where they used to like prick the baby's head. We don't do that anymore, but that's kind of not nice, but that's fair. You'll see how they go along, but that's how you want to think of it though, for sure. Prolonged decelerations are when you have pretty much what I mentioned if it exceeds 2 minutes, but your prolonged decelerations usually are a problem because they go out of range of normal baseline. It looks like this. So baby tanks. Again, you can see that the variability is actually fine, but this is not okay, right? But look at this now. You have 1 contraction, 2 contraction, 3. Each one of these is a minute, right? We don't have 10 minutes, but you could probably figure what's happening here. There's too many contractions, right? That's called tachysystole. So you can give a medicine that would relax the uterus temporarily to relieve this, and then it goes up. Because there's nothing wrong with baby. It's just that baby can't breathe because it's like so. Once that's relieved, it'll go back, and that's also how you know that there's not a worse problem with baby, right? So uterine contractions, they're again 10-minute window, but they're also averaged over 30-minute period for contractions. Okay. That being said, your normal contraction window is 5 contractions or less in 10 minutes. Okay. Tachysystole is defined as more than 5 contractions in 10 minutes. Okay, so that's pretty much what's happening in this scenario. Now, if you have more than 5 contractions in 10 minutes, are you assured to have a fetal problem? Absolutely not. Okay. Sometimes you have a mom, she's contracting every minute. And then, they're like, oh, what are you going to do about it? I'm like, nothing. Good. Go. Is the baby okay? Yes. Good. That helps. We'll have a more efficient labor. But sometimes it's too much for a baby, in which case you have to resolve that. This is an example of where you have tachysystole clearly. 1, 2, 3, 4, 5, 6, and it's not even 10 minutes. And baby's fine, right? Baby's fine. That's it. There's nothing you want to worry about too much. So you would just continue present management there. But if this then started to go like this and kind of hang out here, then you would want to do something to relieve this. And really the only way to do that is what? Does everybody know? Yeah, but how? Someone said it. Beta 2 agonist, right? What's it called? Yep, terbutaline. Terbutaline is what, and that's, I think it's, yeah, see, it's even in this chart. When you're reducing the uterine activity, you want to administer your tocolytic, which is your terbutaline. Okay. Now, this is a chart that we're going to talk about interpretations now, but when talking about uterine tachysystole, OBGYNs love charts. So it says if no resolution, consider a tocolytic, but your tocolytic is always terbutaline. Like you don't have another option, which is a little confusing. So that's why I wrote here. So the primary tocolytic used in the setting is terbutaline. Now you have three tocolytic options. Okay. Your first is terbutaline, we just mentioned. The second one is nifedipine. Now, nifedipine comes in, you don't really got to worry too much about dosing, but here it's important because your immediate release nifedipine is what we're talking about here. And this is the one you use in the context of preterm labor, okay? So if you're talking about preterm labor, when they talk about tocolysis, it's nifedipine. That's it. Nothing else is used. Because theoretically, you think you could use terbutaline, but it doesn't work. It's just because the mechanism is just different. Terbutaline works really well for uterine tachysystole in labor. Does not really work well for preterm labor, which, why not, right? Well, it's a good question. I don't have an answer for you. Preterm labor is nifedipine. And the other one you could use that is indomethacin. You can't use that above 32 weeks because it interferes with the ductus arteriosus. It'll close it too early. And it's not like if they take an indomethacin, the PDA just goes, but but prolonged use of it will get it to close, prematurely. So sometimes there's situations where NSAID therapy is preferred. Like say if you have like big fibroids in pregnancy, and sometimes they'll degenerate because they lose their blood supply because it gets redistributed, and they're in a lot of pain. And really the only thing that touches it is non-steroidal anti-inflammatory. So sometimes they'll be on a maintenance, but then they have to go follow with MFM and have ultrasounds of the ductus arteriosus to make sure it's not closing. So it's not like a one or done, but that's why it's not used above 32 weeks. The only time you'll really see indomethacin used is if a patient rules in for something called a cervical cerclage, which is a stitch around the cervix to keep it to prevent ascending infection in preterm labor. They'll use that for 2 days. And then you'll say, well, I was told you can't use it. Well, obviously that patient is going to be less than 32 weeks. And then you can use it, but it's only for a short amount of time. And it's something that's acceptable to use. But other than that, you won't ever see that used. So really, if you remember, preterm labor is nifedipine, okay? Uterine tachysystole in terms of tocolytic agents is terbutaline, and indomethacin is going to be used usually post-cerclage, or if you're dealing with leiomyomas, but that's not like a standard thing, so they're not going to test you on that. But that is where you'll see it, if you see it at all. Okay, any questions on that? Because that seems to be kind of confusing. It's really just that. So just get that straight in your head, okay? So putting it all together, category 1 is reassuring. There's no specific interventions that you need to do. You're good. Continue present management. That involves a fetal heart rate tracing that has a good baseline, 110 to 160, good moderate variability. Okay. You don't have late or variable decelerations. If you have early decels, great. If you don't, no problem. Same thing with accels. This is what's important to remember. You don't need accels. If you have them, great. If you don't, no problem. This is in the context of a patient in labor, okay? If you have, sometimes you'll, in non-stress testing, which NSTs, you'll hear, oh, patient's here for NST, right? There you do need accels, okay? because non-stress testing is in a patient who is not in labor. And then that's just assessing fetal well-being. For all intents and purposes, it's the fetal heart rate tracing, just as I've described to you. But the criteria are a little different. All right. Then that's what you want. This is what you don't want, which is category 3, because these are abnormal, right? There's a problem. It means that there's some fetal acid-base status at the time of the observation, so you can't just leave it. And you have to resolve it immediately. But it's a very narrow and specific definition. You have to have absent variability and, okay? That means that if you have absent variability, it's not category 3, if that's it. You have to have that and something else. You have to have that and recurrent lates and or recurrent variables, bradycardia, but a sinusoidal pattern is individually a category 3, okay? So that means that if you have absent variability, okay, and you have any of these, you don't need all 3, then you have to do immediate resuscitation, and if not within maybe a couple minutes, then you have to expedite delivery. If you're in a position where you can do an operative vaginal delivery, meaning she's fully dilated, you have to do that. If not, that's an indication for cesarean delivery. And every other combination is category 2. So don't worry about category 2. It's not 1, it's not 3, it's 2. And these are indeterminate, pretty much that it's not right, but you want to try to figure out what's going on and resolve it, but it's not an emergency. Okay. We spoke about resuscitative measures. Just review this, but it's all we just said. So I'll just mention briefly non-stress testing. I've kind of spoken about it before, but this is, again, it's an assessment of the fetal status, but in the context of a patient who's not in labor, okay? And it's defined not in categories, but reactive or non-reactive. Reactive being what you want, non-reactive being non-reassuring. Just remember, not in labor, okay? So this is a little different because you need 2 or more accels, okay? This is why you need it. And it's in a 20-minute period. I kept saying it's over a 10-minute period, 10-minute period. This is a 20-minute period. So you'll hear a shorthand that you'll hear on the labor floor. It's like, all right, so get her in there, get a 20-minute strip. And if it's good, send her home. So meaning that if you have 2 or more accels and you have a good baseline, good variability, all that other stuff rules in. For 20 minutes, you're good. And what that's reassuring, it gives you about a week of reassurance. The non-stress testing is part of a biophysical profile, okay? So your biophysical profile is actually an ultrasound. And sorry. So the biophysical profile really consists of an ultrasound in combination with your non-stress test. Each of those gives you 0 or 0 points if it's abnormal, 2 if it's normal. There's no 1. Why is there no 1? There's just no 1. So your reactive NST gives you 2 points, and then you have 5 other components, which would total 10. Sometimes you don't have the ultrasound component, you just do a non-stress test, and then it's either reactive or non-reactive, okay? Your ultrasound components, which we're gonna go over at a different time, but you have fetal breathing, fetal movement, fetal tone, and amniotic fluid index. A modified BPP, which is what you'll hear, just does your NST and the AFI, amniotic fluid. Okay. And now what you'll do, if anybody gets the reference, please tell me you do. Mortal Kombat 1 on Super Nintendo. Yeah, well, you gotta now put it all together. And I will